everybody, this is Dr. Sathya Bhandari, and this is the series that I wanted to make for patients who were really interested in knowing about the research about mesenchymal stem cells or regenerative medicine. So this is the first one that I'm doing of a long series, so check in every week and I'll have a new article up. Today what we're doing is we're going to discuss articles that have to do with stem cells research in the discs of the back or the spine. Discogenic back pain is a very difficult entity to treat. As many of you know who have back pain, you suffer from it. There's a large population of people all around the world that suffer from low back pain just due to disc pain. We do have little nerves that are in the disc itself, and there's really little that we can do in the sense of insurance covered therapies. We definitely can start physical therapy, definitely start medications. Those are definitely things we can do. Spinal fusion and disc replacement are also the options that are presented to patients. Here I want to talk to you about another alternative, and that's going to be using your own mesenchymal stromal cells or mesenchymal stem cells. We'll just abbreviate and say MSC, which are derived from your iliac crest of your pelvis. So these are cells that are derived from your bone marrow. So the first study that we're going to look at today was published in 2017 in Stem Cell Research and Therapeutics by the author of Kenneth Patine and Tyler Santamasso. So you can see that there in Colorado. We're going to just zoom down here and talk about the kind of people that they had in their study. So if you can look right here, there's 146 patients in their study. The average age was anywhere between 17 to 80 years old, the average being 52.7. So that's a question I get asked a lot. Okay, so am I too old for these iliac crest bone marrow stem cell injections? I always have told people no, but this is a study that it's involved people as young as 17, as old as 80, the average being 52. So the average BMI is really important too. That is about 27, and you've got a pretty decent male to female ratio of 79 males and 67 females. So let's talk a little bit about study design. These people, 146 is a very, very decent number. This is the number of the average age is really what we see in the pain practice. The average age of 52 is very realistic, and an average BMI of 27 is actually realistic to us as well. There are some places in the country, of course, that have higher or lower BMIs, but I think that that's about right. And we really do have around a 50-50 split of male to female. So overall, the study, the people that they picked was very average and makes sense. So if we go and talk about who was actually picked. So let me go into that because it's important to understand. So if you look here, it says patients who were enrolled had symptomatic back pain. They had centralized back pain, so nothing really going down their legs, just localized in the low back. That increased with activity that had been going on for at least 6 months. That's really important because we want to be able to give patients a chance that are going to heal and just let them heal on their own. These people had 6 months at least of non-operative management, so that would include anything like physical therapy, medications, as well as injections. They did not break that down. That would have been nice if we saw how many people got injections versus got physical therapy, or how long their pain had been going on for. But on the average, they had to have had pain for at least 6 months, and it had to be centered in their back. There is something that I look at a lot. Sometimes you may have, in my clinics, been asked to fill this out. This is called an Oswestry Disability Index, and that's right here. The ODI is a way for us to really understand somebody's disability. So if we ask somebody what their pain level is, for the most part, they'll say, oh, it's mild, moderate, or severe. If we ask you to quantify it, then you're going to go on to the visual analog scale, which I'm going to show you, and then you're going to tell us, from 0 to 10, 10 being the worst pain, how bad is it? The other way of discovering how much pain you have is to figure out how much it really impacts your life. So let me go and show you what that means. This is the West 3 Disability Index. Let's look at that really quickly. It's really simple. There are just 2 pages. There's 10 questions. Going over it really quickly, pain intensity, personal care, such as washing and dressing, lifting, walking, sitting, standing, sex life, social life, sleeping, and traveling. If we look at section 10, which is traveling, we can travel anywhere without pain, and then breaks it down to the last one, which is pain really prevents me from traveling except to receive treatment. So those are people that really don't leave their house a lot because it hurts too much to do that. So overall, this is all about function. So this is what the West low back disability pain questionnaire looks like. When you grade it, this is how you grade it. The interpretation of goals, of the interpretation of the score. Okay, so this is the West 3 Disability Index. It's a really pretty simple questionnaire. There are 10 questions. They go from I have no pain at the moment to the pain is the worst imaginable at that moment. So it looks at pain intensity, personal care such as washing, dressing. Can I look after myself normally without causing pain, or do I need some help, or I can't even get dressed, I need help. Lifting, walking, sitting, standing, sleeping, sex life, social life, and traveling. So how do we score this? So when somebody ends up filling that out, you get a score. If you're 0 to 20, you have minimal disability, 21% to 40, moderate disability, 41% to 60%. That's pretty severe disability. So what does that mean? That means that pain remains the main problem in this group, but activities of daily living like washing, grooming, brushing your teeth, doing things like that are affected. So you may not, wash yourself every single day because you may have too much pain. So you may take a shower every other day or every third day because it just takes too much energy out of you and you may have too much pain. Things like that. And then these patients require detailed investigation. So that means that there's really something pretty wrong and we need to figure this out. 61 to 80%, these people are crippled. The back pain impacts them throughout their entire life, from the time that they're, up to even when they're sleeping. And it's required that we do something about it. If they have 81 to 100%, these people are really kind of bedbound. They're not even able to get out of bed because their pain is so much. So now the next thing I'm going to show you is something called the VASC pain scale. And what I want you to look at is this scale. You guys have seen this all the time in my office. When we grade this in a study, we obviously can't say it's a 6 or a 3. What we do is, I'm going to skip over to here, is we use this VAS, that's a visual analog scale ruler. So we put this really over the patient's pain score, 0 being no pain, and then 10, of course, being severe pain. And then what we do is we count how many millimeters there are. So if they kind of circle over here, then they would be somewhere between, 65 millimeters, right? So this is how we end up counting. Each one of these is a centimeter. Okay, so we're back. All right, so let's talk about this again. Just reviewing, there's 146 patients, right? BMI of 27 average age is 52, and about a 50-50 split when it comes to male to female ratio. Who got included? Patients who had at least 6 months of back pain, at least 6 months of therapy or injections or some type of intervention. And they did not name that. That would have been nice if we got a kind of breakdown of who got what. You can imagine that maybe people got better if they got more steroid injections or what have you. But what's important to look at is what I talked to you about is this Oswestry Disability Index. They had at least an ODI of 30 over 100. So they were in that medium to moderate disability. And they had a pre-treatment baseline of low back pain of at least 40 millimeters. So they were kind of right in that middle of moderate pain. And so they didn't pick anybody that had very mild pain. They picked people that had at least 4 or above pain scale. So how do they collect and process it? This is the way I do it. So I use Dr. Hernigo's technique, and so that's how they did it. They did one injection with using a Jamshidi needle, which is what we do, right into the pelvis of the back, and would draw small aliquots of aspiration, 5 to 10 mLs with a total mLs of 60 mLs. And so that's what they did. And how do they do the injection? Similar to how I did the injection, they used x-ray guidance. That's what fluoroscopy means right here. And they injected it with an 18 gauge needle against into the annulus, and then 18 gauge needle that touched almost the annulus, and then they went in with a 22 gauge needle. That's how we do it in our office. They injected about 2 to 3 mLs of the bone marrow concentrate in there. And really the entire procedure averaged about 45 minutes. So it's kind of aligned with what I do in my office. Post-treatment is really important because, if you're not doing anything or you're really medicated for like 2 full weeks, you probably won't have any pain. So if you're measuring that pain scale during that time, of course, people are not going to have pain. So patients were prescribed pain medication to use, but it was only for 3 days. And then they were put on restricted physical activity for 2 weeks. In my office, I do that for 4, and I use a back brace, and I usually give patients a good amount of pain medication for at least 3 to 7 days. That's how we do that. All right, so let's look at something really interesting. This is their data. So this is at baseline. This is a 0, right? So the date that they injected the patient. The Oswestry Disability Index was at 41. Their VAS pain scale was at 62. These are obviously averages. And then in 3 months, their ODI went to 14. So that's a huge drop. That's a 65.3% drop. And then their VAS scales went from 62 to 21. And that's a 66% improvement. And this little asterisk here that you see, an asterisk right here, means that their p-values statistically were less than 0.001. This is significant difference. In 180 days, if you look, you still maintain that 14 to 16, 21 to 22. You have a 59% improvement and a 63% improvement. And then at 365 days, so a whole year, what they did is they continued that improvement at 64% and 69% improvement from their baseline. This doesn't mean that patients were only improved to 69%. This means that there was a 69, almost 70% improvement from the time that they were injected to a year out. So that's pretty amazing. This is the distribution of how many discs or which ones they injected. So they really injected as many as up to 3 discs. So the T12 to L1 disc they only had 5. But if you tally all of this up, it's obviously going to be more than the number of patients because they were allowed to inject as many discs as they thought appropriate, up to 3. So L23 was 83, L34 at 135, and you can see the majority of the discs are going to be the lower numbers, which is what we know in medicine, that most of the time it's the lower number of discs that are painful. So that's really not a terrible thing. Down here, let's look at a chart. So they're looking at this chart, which is basically this, just in a different chart. So you can see how wonderful you get that decrease both in the osmosis disability score and the VAS scores, how they decrease from day 0 to day 365. So let's talk about their discussion, which is really very interesting because they talk and compare the results from a fusion surgery study to their study here. And so they're going to be looking at, in the discussion, let's look at the study here. They're saying that 12 prospective randomized studies were reviewed comparing various fusion techniques with a minimum of a 2-year follow-up. So this is actually really great study. These patients, again, were restricted to 1 or 2 levels, so they only had 1 or 2 level fusions or 1 or 2 level disc replacements, which is currently what is recommended by many spine surgeons, unless there's some really major issue. But for discogenic back pain, that's really what's recommended. So what are the results? The results were that 43% improvement in back pain. That's 1,420 patients. That's a really large number of patients. And those patients had a reoperation rate of come on guys, let's look at this, of 15.3%. I mean, that's huge. And I see this in my practice. There are definitely reasons to have surgery, but if we can do this differently, why not? And this study definitely tells us that we can do it. Okay, this is the other study that I talked to you about. This is the treatment of discogenic back pain with a minimum of a 2-year follow-up by the same doctor, Dr. Kenneth Patin and his group. It was published in 2015. So very similar criteria for getting in. So the patients had the visual analog pain score of at least 40 millimeters or more at the initial visit. The initial osmosis disability index score was like 56.5%. So really these were pretty debilitated patients. So let's talk really quickly and go through this. So they did the same thing. It was an open label, non-randomized. They didn't have a group of people that only got like a saline injection or something else other than bone marrow into their disc. They did do a magnetic resonance imaging evaluation beforehand. They acquired the bone marrow the same way. They injected it the same way that they did it in the other study. So age range overall, there were only 26 patients, so that was a smaller number than before. The male to female ratio was almost 50-50. The average BMI was about the same at 26.6. The age range was anywhere between 18 to 61, so median of 40. So a little bit younger than the other group. The Fuhrman score in the discs, they've got people that are grade 4 or higher. These are patients with pretty degenerative discs. And let's talk about the clinical results. So if we look at the average osmosis disability index and the VAS scores over time, they did it pre-treatment, pretty high, right? And then they looked at it at 3 months, 6 months, 12 months, and 24 months. And you can see this huge drop. And at 2 years, people are still doing at least 50% better. So that's a pretty big deal. These are all values of p-values of less than 0.001. These are all significant. If you look here, this is when he talks to you about the different concentrations. So, this is the solid blue here, which is this guy, is for patients who received less than 2,000 CFUs. Those are colony forming units, and that's the ODI. You can see that the patients who had a little bit higher concentration of more than 2,000, they did better. They had lower numbers and then the patients who had less than 2,000, VAS scores also were a bit higher than the patients who had higher concentration. So you can theorize that higher concentration means better results, but you can see just even injecting bone marrow into that area produces a significant drop in the first 3 months. And so that's what they're showing here. So I just wanted to go over some of these. Let's go right in the middle there. I just wanted to go over, some data based on some really good studies. Of course, there are limitations to every study. There's limitations in every single study, and that's what's great about medicine, is that we actually name those limitations of the study. When I looked at these, I thought that they were appropriate. There is a big difference between the results here and then we see in fusions. We really don't see, when we look at reviews, we just do not see the same ODI differences. We don't see the same VAS score changes even after 2 years, and there's always a reoperation rate. So this is some good data. You're welcome to look through it again. Thanks so much for sticking with me. And if you like this video, please subscribe, and there should be many more to come. Thanks.